but systematic paraortic lymphadenectomy just causes harm in all cancers. And moving forward, this is something that I feel will be abandoned. So I've purposely been controversial in my presentation today because I thought it would promote some discussion, and that's the end of my presentation.
Thank you, Professor Thomas End, for this talk,
Welcome, everyone.
which I think is going to
my name is Dr. Robert Coleman. I'm a gynecologic oncologist.
Okay. Hani Gabra. The next speaker is Professor Hani Gabra from UK, and he is going to speak about new development in regulation of the tumor microenvironment. Professor Hani Gabra, you are welcome to start now your presentation.
Good morning. Can you hear me? Hi, can you hear me?
Yes.
Yes. Good morning. I'm directly presenting my presentation this morning. I had a bit of unfortunate internet failure, but good morning from a sunny Oxford in the UK. I'd like to talk to you about reprogramming of the tumor and its microenvironment, which is an evolving concept, and in particular how this may relate to ovarian cancer through some science that's been evolving over the last few years now. I'm going to try and just how do I show my screen? Let's try this. Yeah, is that better? Can you see the full screen now?
Yes. Okay, fine. Go ahead. Everything is perfect. Can see and
okay, so the tumor microenvironment is obviously a very complex structure. When we talk about it, it doesn't include only the tumors, but also immune cells, vasculature, lymphatics, and therefore it is a complex entity, not just with cancer cells in it. And tumor suppressors act like a brake pedal on cancer, and that's why they are so frequently inactivated by cancers. And typically, tumor suppressor proteins are in balance with the oncogenic system. And when either tumor suppressors are switched off or oncogenes are activated, this results in an imbalance that can drive the oncogenic and cancer process. The tumor suppressor I'm going to talk about is called OPCML. It's a 3-immunoglobulin domain protein, which exists as a dimer. And the important thing about this molecule is that it is switched off in 80% of ovarian cancers and maybe half of all cancers overall in the Cancer Genome Atlas. So very frequently inactivated, typically by a process called somatic methylation. This results in clinical features of bad prognosis. So those patients who have lost OPCML, as you can see from these Kaplan-Meier scores across many cancers, ovarian, breast, lung, and lymphoma here, for example, show an inferior outcome if they have had this particular tumor suppressor inactivated. So how does it work? OPCML, when it's switched normally, negatively regulates receptor tyrosine kinases, and when it's switched off, it fails to do so. So in a typical cancer where you have lost OPCML, if you restore that tumor suppressor, this results in inactivation of a group of receptor tyrosine kinases, which in turn switches off signaling. And the group of receptor tyrosine kinases that are coordinately negatively regulated by OPCML include the HER2 group, HER2 and HER4, the fibroblast growth factor receptors FGFR, ephrin, and importantly, and for the rest of my talk really, what are called the TAM kinases, AXL, Tyro3, and another receptor tyrosine kinase called MER. It is the coordinate regulation of these receptor tyrosine kinases that restores balance to the cell, and therefore the loss of this OPCML suppressor allows these receptor tyrosine kinases to become active and drive cancer. So, as I say, the TAM kinase of receptor tyrosine kinases not only drive cancer cell epithelial mesenchymal transition, but also are intimately involved in innate immune regulation. And they are common in that they are regulated by a high-fidelity ligand called Gas6, which drives these receptor tyrosine kinases. So AXL, which is the senior partner, if you like, of these three kinases, is an important point here is that it's switched on and upregulated in 73% of high-grade serous ovarian cancers. So AXL activation is a key regulator of the tumor microenvironment. So in tumor cells, it drives acquired drug resistance on the right here. It drives immune cell death resistance. It drives metastasis. And it is also a unique type 1 interferon response checkpoint. But not only does it act on tumor cells, it also acts on the innate immune system. And it drives the suppression and paralysis of the innate immune system, which in turn blocks the immune response to cancer. And typically this is seen in macrophage polarization, dendritic cell suppression, and this drives an exhaustion of CD8 positive T cells. And it also maintains the T regulatory compartment. So just to show you, and at the bottom here, just to show you, when you do immunofluorescence of OPCML and this receptor tyrosine AXL, you can see this in red here and the AXL in green. You get absolute superimposition of OPCML and AXL. And this means that they are intimately related and bound together. And so OPCML resides in a part of the lipid membrane called the lipid rafts, which you may know are cholesterol-rich regions of the cell membrane. So the interaction between OPCML and AXL is typically by dragging the OPCML in green, the AXL here in green, into these lipid raft compartments. And as this happens, there is a removal of the active position of AXL, which normally signals, and it's dragged into the lipid raft, this cholesterol-rich region that I just showed you. And this results in inactivation of signaling. So OPCML switches off the AXL kinase by relocating it into a particular compartment of the membrane, resulting in no signaling and no cancer drive. So here are some mice, and you recognize as gyne-oncologists what this looks like. So these are obviously peritoneal models of ovarian cancer, where we've injected the mice with intraperitoneal tumor cells. And here we're injecting this recombinant OPCML that is a negative regulator of receptor tyrosine kinases. And you can see that these mice treated with OPCML are very slim. They don't have this big ascites belly full of cancer. And when you rescue from the bellies of the mice, you see very little cancer as compared to controls. And this relates to tumor burden, number of deposits, and also the ascites formation. So it's a very potent suppressor of peritoneal ovarian cancer. And what does this look like down the microscope? So you're at the top right here, we have transfected OPCML into cancer cells. In the bottom right, we've produced a protein that we throw into the media that acts at the cell surface, both of these hopefully blocking receptor tyrosine kinases and stopping the cancer cells. So does it really work? So here on the left are controls where we don't have OPCML, and you'll see what happens. So as you see on the left, the tumor is growing very fast, closing this gap. On the right, when we either have transfected into the cell, the gene, or we have the protein floating in the media, you see that the cancer cells are completely blocked from their cancer behavior, in this case, a wound healing type of assay. So when you take OPCML and you add to it an AXL inhibitor, a receptor tyrosine kinase inhibitor of AXL, you see this very profound inhibition and synergy between an AXL kinase inhibitor, small molecule, and restoration of OPCML. In fact, there is a threefold synergy in combining RTK inhibitors with this OPCML protein. So therefore, the OPCML negatively regulates the paralyzed innate immune system, switching the suppress and heal signal to a kill signal and activating the immune system through cytotoxic T-cell activation. This also creates synergy with PD-L1 checkpoint inhibitors and drives increased natural killer cell activity and increased dendritic cell antigen presentation. And so the OPCML-AXL ratio is rapidly evolving as an interesting way of measuring the potential of tumors to be regulated by and respond to this approach. And you can see here that you have very clear inferior survival, either if OPCML is elevated, either OPCML is lost and low, or when AXL is very high. So the bemcentinib, as you'd imagine, is as an oral small molecule TKI inhibitor, reprograms the microenvironment through these pleiotropic mechanisms of immune suppression, epithelial mesenchymal transition, cellular invasion, proliferation, and migration. And we've been testing this in Bergen Bio now, which is the commercial development of this approach in clinical trials. And I'm going to show you a little bit of data from lung cancer and then end with how we're applying this now to ovarian cancer. So in non-small cell lung cancer, where patients have received previously a checkpoint inhibitor and are resistant to it, we've been giving the checkpoint inhibitor again, together with this approach of bemcentinib targeting AXL. So like ovarian cancer, lung cancer also has this feature that when AXL is high, and it's a very generic process across all of cancer, there's a very poor survival in those patients. And in biopsies of patients who we're about to treat, we can see that these patients, and this is a patient who responded to this approach, have got very highly immunosuppressed cells. So here, for instance, there's an interaction between a T regulatory cell and the cytotoxic T cell, resulting in inhibition of cytotoxicity. AXL positive macrophages also appear to interact with the T cells here. So you would never expect this patient to respond to a checkpoint inhibitor. And yet in our trial, this patient did. And so we've developed a test for this, which we use to select patients where we can look at both the tumor cell AXL expression and also the innate immune compartment's AXL expression. And this gives you a composite AXL score that allows you to give a sense of the whole tumor microenvironment's AXL status and therefore the potential for regulating both the cancer cells and the immune compartment simultaneously. So what does this look like in terms of clinical results? So here we have a group of composite AXL score positive patients and a group of composite AXL score negative patients, all of whom have already had a checkpoint inhibitor, in this case Keytruda or pembrolizumab. And you can see that only these AXL positive patients, and these are patients that you'd expect, as I've shown you from the Kaplan-Meiers, to do really badly, they are all responding and showing benefit. Whereas the C-AXL negative patients, who typically, from a biological perspective, do better in terms of survival, none of those patients respond, and indeed all of them progress very quickly. So when you do RNA-seq analysis to look at gene signatures in those patients, you ask the question, how do you predict who's going to respond? It is not by PD-L1. It's in fact a signature that is exactly as you would predict, which is the epithelial mesenchymal transition signals, AXL itself, and two highly immunosuppressive types of innate immune cell, these so-called TREM2 positive tumor-associated macrophages, and these CCR7 positive, what are called the MREG DC1s. And these are very hot now in the field as highly immunosuppressive components of the innate immune compartment. So the proposed mechanism is that these two types of highly immunosuppressive innate immune cells result in exhausted and dysfunctional T cells. And of course, this is also contributed to by the immunoevasive mesenchymal cancer state. And this results in an improvement in survival in patients who are AXL positive receiving this approach for treatment versus those who are AXL negative. Now, importantly, the C-AXL positives survive better, but in the natural state, AXL results in a very bad survival signal. And so what we're doing actually is flipping the survival of these patients around through an approach of thinking about the tumor microenvironment and its reprogramming. So switching now to ovarian cancer, taking AXL and knocking it out in peritoneal mouse models results in an over 98% inhibition of peritoneal tumor formation. And both tumor volume and tumor weight are dramatically reduced. When you look in ovarian cancer in the Cancer Genome Atlas, you find that there is a group of high-grade serous ovarian cancers that are very enriched for AXL, and these are called the MES group, the mesenchymal group, and this is equivalent to the C1 group that Botel and the Cancer Genome Atlas developed. And when you look at the signature around this MES group, mesenchymal group, it is an AXL gene signature with genes that you would expect to participate in this tumor microenvironment AXL-driven signature. And you can see that moving from primary to relapse disease, or going from primary to omental metastases, both of these drive a rise in this AXL signature, which, as I've described already, results in an inferior survival for patients with ovarian cancer now. And so this has led to this current study that we are engaged with, which is now not a small molecule inhibitor, but an inactivating antibody that binds to and blocks AXL. And this is a drug called tilvestamab that we have now entered into clinical trials in ovarian cancer, in fact, as of this week. So this is a fully functioning blocker of AXL signaling with a high affinity for AXL, and extensive preclinical data shows that this molecule can effectively block tumor xenograft formation. So we've designed a clinical trial where we are increasing the doses of tilvestamab, and in particular, we are doing sequential biopsies to understand how this antibody blocks AXL and what the impact is on the pharmacodynamics and downstream signaling in ovarian cancer, and whether we can achieve this reprogramming of the tumor microenvironment in ovarian cancer. So this approach to TAM kinase inhibition in cancer therapy can result in both tumor effects and immunological effects, and in the future would be potentially synergistic for the combination of tilvestamab with this OPCML molecule that I demonstrated to you earlier as being so suppressive of ovarian cancer. So in conclusion, reprogramming the tumor microenvironment leads to control of the cancer cell directly and reversal of immunosuppressive innate immunity. And OPCML negatively regulates tyro, AXL, and MER kinases, particularly AXL, and is synergistic with the AXL inhibitor bemcentinib, which is a clinical stage molecule. And this can be directly